Okay, well, good afternoon, everybody. It's now afternoon, so I can say that. So we're going to be talking about epilepsy and degenerative brain disease. And for this, I have worn my special brain CT tie I was given by the American College of Nuclear Medicine. So I'm dressed appropriately, as they say. So we're going to start off with looking at epilepsy, and then we'll move on to degenerative disease. So epilepsy, there's various forms of epilepsy. In childhood and young adults, it tends to be spontaneous, but there are various trigger events. Two most common in women is menarche and pregnancy. And the reason for this is not entirely clear, but these can be the start of people unfortunately suffering from epilepsy. In older patients, it tends to be related to some form of damage, either by tumor or a stroke, and the stroke can be quite small, of course. So epilepsy is not the same as having a fit. You can make anybody have a fit if you try hard enough. If you raise their temperature or you change their metabolism by dropping, for example, their glucose or changing their potassium level, you can induce a fit. Or changing their glucose level. So just because somebody has a fit doesn't mean to say they have epilepsy. So epilepsy is a spontaneous and recurrent fit. And they need to be really observed by somebody else and occurs more than once. Now, there are some patients who suffer from certain triggers, the classical one being flashing lights. But it's important to diagnose this because there are sort of legal issues. For example, in many countries, people with epilepsy aren't allowed to drive. In terms of the types of epilepsy, in fact, the most common is actually something called petit mal. And these are just episodes basically of non-attention. Normally in children, they disappear by puberty. Now, many people may feel their children have petit mal all the time, but this is something which is slightly different from just being distracted. Temporal lobe epilepsy, these patients often suffer from déjà vu, or they may get an odd smell, and that smell is often mildly unpleasant, but it could be a smell from memory, such as frying onions or garlic or something. And again, these tend not to result in generalized fits, and they can be benign. They don't always be benign, but they can be. Then there's the two that we most commonly associate. There's the grand mal fit. Again, it tends to be worse in children. And the problem is that if the fit continues, if, for example, their tongue blocks their airway, they can become hypoxic and they can get ischemic injuries, or they can injure a limb or another part of their body if they fall and hit it. Then there's the tonic-clonic version. These are actually fairly aggressive forms of grand mal. The patient may not lose consciousness, but they may have one limb which becomes both tonic and clonic at the same time. And this is often the most difficult one to treat. So diagnosis and treatment is primarily based on history, observation, EEG for delta waves, CT or MR to exclude organic disease. And the treatment is with anti-epileptics. Now, there's quite a lot of very good modern anti-epileptics, which aren't as sedating as the old-fashioned ones. Also, the older drugs chronically seem to affect cognitive function, which the new ones don't. However, severe fits may still be very difficult to control, particularly in some children. So the role of nuclear medicine is limited, but it could be used to look for the nidus of the fit, and that could be then used to direct surgery. Now, this is really a specialized area and tends to be done mainly in specialist pediatric neurology units or nuclear medicine departments related to those. The problem is if you take a scan between fits, it can be normal. So you need to have a fit that that you can induce, and that often is done with flashing light. And you need to be able to inject a tracer during the fit and look at the different patterns of uptake between the fit and the non-fit. So these patients tend to have frequent fits, and they tend to have a recognized trigger. So this is something called ECD, which is a bit like HMPAO. And this is an ictal study. This is not mine. You can see it comes from a website. And it shows increase in perfusion in the left temporal lobe. Now that's because there's an increased blood flow at the site of the fit. Now you could argue you could do this with PET, but the issue with PET is often that you need to be able to do this in a very controlled way, and PET departments are often very busy. And also you may get changes in blood flow, but not metabolism, and not many PET centers have either an oxygen generator or a cyclotron to make ammonia. So there's actually quite a good literature in SPECT in epilepsy, 1,600 papers published at least. But despite that, it's still not very widely used. And I think the reason being is it really needs to have a very specialist interpretation. And some of these specialist centers do subtraction imaging between the interictal and the ictal, and they try and fuse images into MR for localization. So here we have an ictal SPECT. This is another one from the Women and Children's Hospital in Boston. And you can see that, interestingly, when the patient is having a fit, the generalized blood flows again in ECD scan is reduced compared to the resting interictal one. But there is a nidus around the sort of hippocampus, which is has increased uptake compared to the interictal one. And this is our nidus of the fit. That wouldn't be very easy to operate on. So you can do subtraction imaging. This is a technique that we have used occasionally in the past. We don't do it very often. We used to do it 2 or 3 times a year, and now it's been a few years since I've done it. So we give half the activity. This is, let's say it's for an adult of 350 megabecquerels of HMPAO. Wait a couple of minutes, then image for 30 minutes, and the patient stays still. Then you have to do your fit induction. And during the fit, you then inject the second half of the HMPAO. But because we've got double the activity, we can just reduce the imaging time to 15 minutes. And then they're meant to have equal activity because one is 30, one is 15, with double the amount of activity on board. So you're meant to be able to subtract the images. So that's the theory. And this is the kind of image you get. And again, this is not one of mine. This actually comes from Great Ormond Street, which is a pediatric hospital. And this one, the patients were actually scanned on 2 different days, but they were lined up using a Hermes computer system. And when you look visually at the ictal and the interictal, you don't really see a lot of difference. The only difference is really some suppressed activity in the left-sided parietal lobe. Now, when you do the subtraction, the areas which are hotter on the ictal scan are red, and those that are colder are blue. And you can see in this patient, there seems to be multiple sites of increased uptake. So this patient, again, wouldn't necessarily be one you'd want to operate on because quite a lot of the brain seems to be involved in the production of the fit. This is another example. This one is another example from Great Ormond Street. This is a patient who's had a stroke. Young patients had a stroke, and then they've had a sort of nidus of the fit, which is then marked out on the MR scan. And here you can see that it's pretty much associated with the base of the fit. This patient might benefit from an ablation or surgery. So there was quite a lot of interest in this about a decade ago, and so people looked at this. This is mainly from the US and from Japan. The Metasadix group used localization on, they laid the subtraction image over the MR, just as I've shown you, and this showed very good localization, but found the technique very difficult to do. Goltan and Wishartan are both in the US, and they found that FDG wasn't particularly helpful, partly because metabolism is affected less than blood flow initially. but they did show the uptake of HMPAO at the site of epilepsy in the ictal scan. And Wishartan is probably the leader in this worldwide. And they were able to demonstrate that in about half the patients which they could get localization, they could cure the patient's epilepsy by surgery, but it's only 50%. So why is it not more widely used? Well, to be honest, most people don't think that surgery for the treatment of epilepsy is really the right path to go down. It's obviously a fairly destructive process, and the patients may be left with neurological deficits. These new GABA receptor agents are much better at controlling the fits or reducing the extent of the fits. Obviously, some patients don't want to have surgery. And the other thing is that people have developed this idea of tomographic EEG, which has to some degree replaced SPECT. So here we have the sort of mask that's worn by the person. I don't think this person's having a fit, he seems a little happy. But you can see that you can put these detectors all over in a sort of hat thing. It almost looks like one of those masks that are worn by Mexican wrestlers. And then there's a whole pile of leads that come off that. I mean, presumably at some point this will all be Bluetoothed. And you can get a tomographic image which shows you the nidus of where there is a fit. And you can see here it comes from the right frontal lobe. So that's epilepsy. So I just did it to just cover the topic. But you depend whether or not you get asked to do any scans, and it really depends on what kind of patients your department has or your hospital has, and whether or not there is a specialist centre that deals with this. So we're going to move from something which is rare to something which unfortunately is increasingly common, and that is dementia. So we think we all know what dementia is. We may even unfortunately have relatives who have suffered from dementia. And the most obvious thing that we have is the loss of cognitive function, particularly seen as a loss of short-term memory. And then a loss of emotional stability. So these patients may become, for example, very depressed or quite tearful. Occasionally it becomes sort of almost over happy. That's seen in a few patients. In a few patients also, they may have mobility problems. Now, if they forget where they live, having a mobility problem might be a good idea, as well as they might then wander off. And I'm sure we've all heard stories about people who've been found wandering around, not knowing where they are, or looking for somebody who died years ago. The most common cause is Alzheimer's, by far the most common. And then we have the more specialist one, Pick's disease, Vascular, which is also common, particularly if you are in an area where hypertension is not treated very well. So various famous people have suffered from vascular dementia, including, as you know, our Prime Minister Margaret Thatcher. And you might argue that there's some people who's still presidents and prime ministers who's got vascular dementia, but that's another question. Lewy body and Parkinson plus multisystem atrophy are a family of diseases, and we will look at those rather differently. Now, bizarrely, the population of the world is aging quite fast. Generally, birth rates are dropping across the world, which is probably not a bad idea in terms of population control. But that will mean that the number of old people will increase. And the WHO considers that by 2050, dementia will be the biggest health problem on Earth, and that includes Africa and even sub-Saharan Africa. The main diagnosis is by history, and then looking at the kind of cognitive dysfunction. Is it behavioral or is it memory? Does it slowly get worse over time, or does it go down in what we call stepwise, which would suggest a more vascular cause? Is there a family history? Unfortunately, if your parents or grandparents had Alzheimer's, the chance of you getting Alzheimer's is increased. Other factors that thought to be to play one was aluminium ingestion. I think that story is probably pretty gone now. But if you had high concentrations of aluminium injected, which some patients did when they had renal dialysis in the 60s and 70s, these people developed dementia. But just cooking your food in an aluminium saucepan isn't going to do it, or wrapping it in aluminium foil isn't going to give you sufficient aluminium. Brain surgery, or even being a brain surgeon, and this is due to something called new variant CJD, which is a prion, which is highly infective and transmissible. The most important lab test is a blood pressure because of vascular dementia, and of course you can have Alzheimer's and then added vascular dementia, which makes it deteriorate more quickly. Vascular studies of the carotid arteries are important. Blood sugar to exclude diabetes, another risk factor for vascular dementia. Thyroid function tests, because hypothyroidism can mimic dementia. So you just need to make sure they don't have that. And likewise, high calcium and hyperparathyroidism can mimic dementia. And then normally they have a CT or MR that looks for atrophy, which is a sign of particularly Alzheimer's, but also to exclude anything like infarcts or tumor. And what can we do in nuclear medicine? Well, we can do some SPECT studies, and we can do that with IMP, which is a amphetamine type substance that's used almost exclusively in Japan. And then we have HMPAO and ECD looking for brain perfusion studies. And when not use HMPAO or ECD, depends which part of the world you're in. In Europe and Africa, we tend to use HMPAO. The US tends to use ECD. And ioflupane, I'll talk about at the end, that's to do with Parkinson's disease. And then with PET, clearly FDG is useful. We use that quite a lot in terms of diagnosis. And then we can use amyloid imaging, and if we want to do specialist work, things like ammonia. The HMPAO, the advantage of that is its uptake is proportional to cerebral blood flow. These days we tend to use stabilized, so that's all works very well, and you can inject and then scan at 5 minutes. Now ECD, which is a diester, has high uptake at low flow and low uptake at high flow, so it's not quite proportional. The medial temporal lobe, it's how written that as medical, but it's actually medial temporal lobe is reduced compared to HMPAO in a normal patient. So don't read every ECD as dementia. Now, the other thing that people forget with ECD is that you need to wait until the scalp activity is cleared. So you've got to wait 30 minutes before you scan. So here we have a nice, this is from the our professor of neurodegeneration in Cambridge, and he did this very nice map showing what you would see in a normal brain. So you see a fairly smooth distribution of activity in most parts of the cortex, and you see the cerebellum having the same kind of level as the rest of the cortex, and the cortex itself looks quite thick and chunky. And then when you get into actual dementia, this is a few patients that we studied quite a long time ago now. And you can see here, this is with HMPAO, that there is quite significant reduction in activity in the temporal lobes bilaterally. So the temporal lobes, particularly the medial temporal lobe and the lateral temporal lobe, are very commonly affected in what's known as dementia of Alzheimer's type, or DAT, not to be confused with TAT scan. Pick's disease, which has a lot of behavioral issues, tends to pick off the frontal and temporal lobes. So you get the same kind of temporal lobe issues as you do with Alzheimer's, but here in the frontal lobes you see significant reduction, and you can pick this up quite nicely with FDG PET as well. So if we were to compare the two, the normal brain here, you see a fairly homogeneous distribution of the tracer. With Alzheimer's, it's a temporal and parietal disease, so you see it towards the back of the brain, and in PICs you see it towards the front of the brain. So that's how you compare them. And this is again similar patterns. but this is patterns that we see in with FDG PET. So you can have these patients don't have PICs, they're just Alzheimer's. So one of them, you can see there's quite a lot of atrophy. There's big ventricles in both patients. The patient on the left has a parietal primary type defect, and the one on the right is mainly in the temporal lobes, and the parietals aren't affected. So you can get different patterns within Alzheimer's. These weren't patients scanned for Alzheimer's, by the way. These were patients scanned for cancer, but they happen to have dementia. So how does this all happen? Well, we don't really know is the answer, but we're beginning to get a bit more knowledge. So first sign is the presence of these beta amyloid proteins. And then you can get some triggering of amyloid sheets. And then we get tau proteins. And then there's more amyloid sheets come in. And that's when you get the neurofibrillary tangles, which is the first irreversible step. And this involves a local inflammation. So what happens, you get the vessels around this area become quite sticky and inflamed, and you can get microinfarcts and cell death. So the only real discussion is this bit between tau and amyloid, and there has been quite a lot of work on that recently. So looking at the tau and the amyloid, so these tangles that we see, this is from Harvard, you can see that these tangles here of tau protein, and just near them, there's these stimulated plaques. Now, tau is not just occurring in Alzheimer's. Wherever you get any damage to the brain, you get tau. So if I took a mallet and walloped you on your head, you would develop tau, which is part of the healing process. But what seems to happen is that it over triggers and you get a continuous cycle of damage. Amyloid, the amyloid causes more damage, which causes more tau, which causes more amyloid, which causes more damage, which causes more tau. So can we image the beta amyloid? The answer obviously is yes. Now the only problem is that by the time we get to 70, we all have beta amyloid in our brain. All our brains degenerate. It's just the speed at which they degenerate that's the issue. So at the moment, we don't image patients over 65. We tend to like to image patients in their 50s with early, what we call cognitive impairment, because that's maybe an early sign that they're going to get Alzheimer's. Now, when you have a negative study, the amyloid just gets dissolved in the white matter. But a positive study is when it's taken up in the grey matter. And it should be in at least 2 lobes of the brain. So the agents used, traditionally they use something called C-11 PIB, which is the Pittsburgh agent, but obviously that's not very useful because of the carbon 11 label. So there was Flurobetapir, which is the first commercial agent with a fluorine, but that's no longer available. So most people now use Flurobetapen, which is distributed through the Siemens company. And overall, the sensitivity is 90%, with a specificity about 85%. And that lower specificity is related to the fact that when you get any kind of brain injury, you can get tau and amyloid. So these patients may have vascular injury, for example, but they still get tau and amyloid. So, and this was all done, it was a very long study because they scanned patients with dementia, then they had to wait till they died until they could take their brains out and look at them under the microscope. The other thing they worked out is if you have atrophy, you have very little grey matter, so there's nothing really to take up the tracer. So if you think of these tracers, now this is with C-11 PIB, but it looks exactly the same with Flurobetapir, Flurobetapen, is that when it's normal, it looks like a tree in winter. Now, I know that for some of you, winter is a bit of a strange idea, because certainly if you're up in Gauteng, winter can be warmer and more pleasant than summer. But those of you who've been to the Cape know that in the winter, some of the trees lose their leaves. So this would be a European or North American tree. And in the winter, they lose their leaves. And so it looks like you see the trunk and the branches, but you don't see the leaves. And a positive study, this is a tree in summer, or an African tree most of the year, I suppose. And here you see uptake in the cortex. So it looks more like a tree in the summer. Now, this one also, you can see most of the amyloid is in the frontal lobes. So this patient is heading towards a frontal temporal type dementia, a sort of PICS dementia. But this patient doesn't have dementia yet. They're only 55. They're just heading in that direction. Just to show what Flurobetapir looks like, is very similar. And these are all different patients. There's 3 negative patients on the top row, 3 positive patients on the bottom row. So the next one is Tau. So Tau is this marker of damage. So you get Tau released whenever you get neuronal damage. So the Tau and amyloid, it's a bit chicken and eggy. So you're not sure which is coming first, Tau or amyloid, amyloid or Tau. And as people do research, it swaps between the two. But we do know that they're both present. And Tau in some patients can be much more sensitive to these patients developing Alzheimer's than amyloid. So as we said before, it's not specific. It can occur in any damage. But if you, for example, I did hit you over the head with a mallet and you got Tau, within about 12 to 24 months, as long as it didn't kill you, but just bonked you gently, enough to get a bit of brain damage, then it would take about 24 months for that Tau to clear. Interestingly, in patients who suffer from schizophrenia, they have Tau very early on in their life. And some people consider schizophrenia to be an early onset dementia. And if you think of some of the symptoms that people with schizophrenia get, they're very similar to that people with advanced Alzheimer's get, including the hallucinations and hearing voices, etc. And as we said, we do see it in early Alzheimer's. So this is a Tau image. And you can see here in the temporal lobes, quite a significant amount of Tau protein being deposited. And this is a very early signal for quite extensive disease. Again, this is a young patient. It's a patient in their 50s. They don't yet have dementia, but they're just becoming a bit forgetful. But this patient has already started on that track down towards Alzheimer's. These are some other agents. This is another agent which comes from Japan. And you can see there's a normal patient. And in the middle is a 50-year-old patient with moderate cognitive impairment. That's early symptoms. And then there's the Alzheimer's patient, AD. And this patient's just in their 60s. They're the same age as me, and they've already got extensive Tau, particularly you see in the temporal lobes, like we saw in our patient that we scanned. And that's a very potent sign this patient is heading towards dementia very rapidly. So the other thing has been, what about inflammation? And this is where a lot of work has been done fairly recently. And we know that if people have a brain trauma, then they are much more likely to get dementia. Now, I don't know what it is like in South Africa, but we've got a big thing at the moment in rugby players. So rugby used to be an amateur sport in the UK. You weren't allowed to be paid for playing it until about 25 years ago. And when it was played as an amateur sport, many rugby players only played occasionally. And they would do maybe one practice a week and play at weekends. And the number of times they got knocked out in their career was much reduced. When it became professional, as professional athletes, they would train multiple times every week, most days, and they may play 1 or 2 games a week for their club. And the number of times that they were knocked out rocketed. Something like 30 to 40 times higher times that they were hit on the head playing professionally than when they were amateurs. So some of the earlier professionals in the UK game, and I don't know the situation in South Africa, I know you have professional teams, I don't know when that professionalization occurred, now are in their 40s and 50s and suffering from very severe dementia. And this is because their brain has been repeatedly damaged. They've got Tau signals, amyloid has been deposited. The same has been seen in American footballers, though they tend to wear helmets, which protects them to some degree. And clearly this has been known for quite a long time with boxers. So we get this thing called the translocator protein, TSPO, which enables white cells to pass across the blood-brain barrier into the brain and cytokines to come in. And very interestingly, certain drugs like temazepam seem to use this transmitter as well. And particularly T lymphocytes get it recruited, and they seem to cause the damage that results in these neurofibrillary tangles. And there is an agent called C-11 PK11195. That's a really trendy name, that is, which can find these receptors. And there's some other agents as well, G180. None of these have got proper names. They've just got sort of made up names. This is not my study. This is a study from the US. And you can see here that the normal person has very little PK11195 in their brain, but the patient with Alzheimer's disease does. And that means that their blood vessels in their brain are sticky. And sticky blood vessel also increases the chance of micro infarcts, which increases the brain damage. So you get a vicious cycle. Once this is set up, it's why it deteriorates, because it just keeps getting worse and worse and worse. So this is some work that was done in our group, looking at the relationship between tau and vascular stickiness. And I'd like you to mainly look at the top group. These are patients with fronto-temporal dementia. And you can see that there is, if you look on the right-hand panel, this one here, that's tau, and this is the stickiness, the TSPO. And you can see that there is, here in this temporal lobe, significant amount of tau damage being done, and that's where you get the stickiness in the vessels. So this gives us a very good correlation between the stickiness and the non-stickiness. These are other groups who have non-tau dementia, showing that you don't really get much distribution of either tau or the stickiness. So there is a significant relationship in the binding of this tau and vascular stickiness. Now, very interestingly, we found that this drug, this TSPO, could possibly be blocked by calcium channel blockers. Now, at the moment, the ones that we have in existence, like verapamil and nifedipine, we can only give, the only doses that work in the brain stop the heart from working. So we need to find a more specific calcium channel blocker, which doesn't affect the heart, but kind of maybe stop this vicious cycle. So that's Alzheimer's. Let's look at some other ones, and particularly the Lewy body dementias, because nuclear medicine has a key role there. Cognitive loss with rigidity. It's a complex disease, and what we're looking for is basal ganglia damage. You may see reduced uptake of either HMPAO, FDG, but it's not really very good. What you're really looking for is use a specific agent. Now in the UK, we have iodine 123 ioflupane. In many places now, they have technetium trodat, which is a technetium label product, which is produced by the GE Healthcare, which is much easier to use. And to be honest, they all look the same. Now, the problem is it's a non-specific answer, because it could be Parkinson's disease, it could be multisystem atrophy. However, it's the symptom pattern. So Parkinson's disease is primarily motor, Lewy body dementia is primarily cognitive, and multisystem atrophy gives you sympathetic denervation, so they get heart failure and the postural hypotension. But they're probably all facets of the same disease, and they all sort of die of a sort of dementia and mobility issue about between 2 and 5 years normally after diagnosis. They tend to follow the same pattern. We could use a variety of agents to look at Parkinson's, because obviously it's involved with the DOPA system. So we could use fluorinated DOPA, but it's quite difficult to buy, to make. It costs thousands of dollars, euros, pounds, tens of thousands of rands to purchase, and half the time it doesn't come. So what people have looked at is a cocaine derivative, which is involved in the reuptake mechanism. Now, it doesn't have any of the fun side of cocaine. It just uses the same mechanism for uptake. So don't feel that you can space out on ioflupane scans. That won't happen. So the two that have been used is the iaflupane or FPCIT and Trodat, and they work on the same way. One just happens to be technetium labeled. And because they involve the presynaptic cell, they tell you when those cells have died. And so Parkinson's is a degenerative disease of those presynaptic cells. The big advantage is, unlike F-DOPA, is the patients can carry on taking their anti-Parkinson's medication. So basically, all these Parkinson's syndromes, including Parkinson's disease, involves the destruction of the basal ganglia. Obviously, it could occur due to trauma or stroke, but we're looking really at the degenerative ones. And as I said, these are often sometimes called Parkinson's plus syndromes because of the fact that they nearly always occur with a Parkinson's disease symptoms. And as I said before, you get frontal lobe and movement disorders in Lewy body. So if you're having problems with moving and cognitive impairment, consider these. You could also do Alzheimer's studies as well, but to be honest, these tend to be a bit more useful. Sometimes the basal ganglia are still complete, in which case, if you're looking, they almost all, because they're the same family of diseases, along with multisystem atrophy, they tend to have sympathetic denervation. So you could do MIBG quantification in the heart to look for reduction in cardiac uptake of MIBG, which is fine as long as they're not diabetic or they've got heart disease. And all those things occur in old people. Sometimes that doesn't work very well. So imaging with that scan, you can do this nice little rating thing, which is quite nice. So Anna Katafu, who worked in Barcelona, put this together. Very nice little thing. So when it's a normal basal ganglia, you get like speech marks or 2 commas. When you're abnormal, the first thing that disappears is the putamen uptake. So your commas turn into full stops, or if you're American, periods, which does nothing but confuse people in Britain why it's called a period. But that's probably South Africa use the same, meaning the word period, not a full stop. By the time you're getting to a second level, there's no putamen uptake, and there's just caudate nuclei, and then those disappear as well, and you get more cortical uptake. This is quite symmetrical. In my experience, and we do 5 of these a week, so it tends to be a bit more asymmetrical than that. So this is MIBG, multisystem atrophy. What you do is you measure the uptake in the lung compared to the heart at 4 hours. And if the lung is basically hotter than the myocardium, as it is in this patient, then the patient may well have multisystem atrophy. It's not a diagnosis, it points to the diagnosis. So, in summary, the nuclear medicine techniques provide subtle and accurate answers to the cause of cognitive impairment, and hopefully we'll understand more about what's happening in cognitive impairment. But early identification of disease will be essential if we're going to have disease-modifying disease. By the time you get the neurofibrillary tangles, unfortunately, you're probably going to be set to get more dementia. So when we know what we're doing, we should be scanning patients in their 50s, not in their 60s, 70s, or 80s. So this is just a series of FDG PET studies, which just shows you there's a healthy control. This is a 60-year-old with dementia, with Alzheimer's type, a 64-year-old with very severe dementia. These aren't, I'm 61, so this is my age group. This is multi-infarct dementia in a 50-year-old, but a heavy smoker. This is Pick's disease with the loss of the frontal side. And this is a 59-year-old with severe Alzheimer's, so much so that she can't even speak anymore. So these are serious and significant diseases. So I will just stop.